Hello and welcome to your ultimate guide for the DANB Radiation Health and Safety exam. My goal today is simple: give you everything you need to fully understand the key concepts, master them, and walk into your exam with total confidence. In this video we'll cover radiation physics, radiation protection, imaging techniques, infection control, radiographic anatomy. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website offers free exam guides and practice questions to help you ace your exam. You'll find the link in the description below, so be sure to check it out and get the resources you need to study smarter, not harder. So let's get started.
Question 1. An image that came out far too light or underexposed generally requires. Your options are A. Brightness software only. B. A longer PID. C. A retake with more exposure. D. A higher contrast setting. Which one is it? Pause the video if you need more time. The correct answer is C. A retake with more exposure. C is correct because a grossly underexposed image is noisy and missing recorded detail, so software cannot rescue it. The correct response is a retake using more exposure to capture the information properly. A is wrong because brightening underexposed data only amplifies noise without restoring detail that was never captured. So software adjustments alone cannot rescue a genuinely underexposed, noisy image. B is wrong because a longer PID reduces magnification and lowers beam intensity at the receptor, which would tend to lighten the image further rather than correct the underexposure. D is wrong because a contrast change rearranges the tones already present, but cannot add the missing exposure. The underlying problem is too few photons, which only more exposure solves. Radiographic exposure is the quantity of X-ray energy recorded by the image receptor as signal. Every grey tone on a finished image traces back to photons that actually struck the sensor and were counted. Understanding why software cannot fix a starved image starts with separating these two stages. Digital imaging splits into two distinct stages that film once fused into one. First, the receptor counts incoming photons and stores a raw signal. Then, separately, software maps that signal onto a screen. Brightness and contrast controls act only on the second stage and cannot invent data that was never recorded. Where adequate exposure produces a smooth field of many counted photons, severe underexposure leaves only a thin scatter riddled with random electronic noise. Raising a brightness slider lifts that noise in exact step with the faint signal, producing a brighter field of grain, not a clearer field of anatomy. The detail separating enamel from dentin was never encoded, so no filter can draw it back out. Enhancement tools do impressive work on well-exposed images that need tonal adjustment, but they cannot rescue a starved image. Brightness and contrast merely rescale numbers that already exist. They amplify noise alongside faint signal and cannot invent counts for regions where almost nothing was recorded. The correct remedy is always a retake at higher exposure. Information must be captured before it can be shown, and only exposure captures it. When a STEM describes a grossly underexposed image with missing detail that cannot be salvaged by software, the answer is more exposure through a retake, never a slider. Question 2. Because the velocity of all electromagnetic radiation is constant, wavelength and frequency are. Your options are A. Inversely related. B. Directly equal. C. Completely unrelated. D. Always identical. Take a second. Which answer would you pick? The correct answer is A. Inversely related. A is correct because since the speed of light is fixed for all electromagnetic radiation, wavelength and frequency must change in opposite directions. As one rises, the other falls, which is the inverse relationship. B is wrong because calling them directly equal would mean both numbers match, but they are different properties that move oppositely, so they are not equal to one another. C is wrong because the two are tightly linked through the constant speed of light, so describing them as unrelated ignores the very relationship that the fixed velocity creates. D is wrong because wavelength and frequency are never identical. They are distinct measures bound in an inverse pairing, so treating them as the same value misreads the physics. Electromagnetic radiation, including X-rays, visible light, and radio waves, all share one unbreakable rule. They travel through a vacuum at exactly the same speed, the speed of light. That single constant is the key to understanding how wavelength and frequency relate. Wavelength is the distance from one crest to the next. Frequency is how many crests pass a fixed point each second. When crests are spread far apart, fewer pass per second, low frequency. When crests are packed tightly, many pass per second, high frequency. The relationship is captured in one equation: speed equals wavelength multiplied by frequency. Because the speed of light never changes, these two quantities are locked together. If one goes up, the other must come down. It is worth naming the four possible relationships clearly. Inverse means one rises as the other falls, the only option consistent with a fixed speed. Direct, equal, and unrelated all violate the constraint that the product of wavelength and frequency must always equal the same constant. Whenever an exam stem mentions that the velocity of electromagnetic radiation is constant and asks how wavelength and frequency relate, that fixed speed clue points directly to the inverse relationship. Short wavelength always means high frequency, and high frequency always means higher energy. Question 3. Standard precautions are based on the principle that the dental team should treat. Your options are A. Only visibly sick patients carefully. B. Visible blood alone as a hazard. C. Known carriers only. D. Every patient is potentially infectious. Before I reveal it, which one do you think is right? The correct answer is D. Every patient is potentially infectious. D is correct because standard precautions assume that any patient could carry a blood-borne infection, so the same protective steps are applied to everyone, which removes the need to judge infectivity from appearance or history. A is wrong because treating only visibly sick patients carefully would miss the many infectious people who look perfectly healthy, which is the very gap that standard precautions are designed to close. B is wrong because focusing on visible blood alone ignores saliva and other fluids that may carry infection, so it falls short of the universal caution standard precautions require. C is wrong because limiting caution to known carriers fails because most carriers are never identified, so the protective routine must extend to every patient rather than a labeled few. Standard precautions are a single, uniform set of infection control steps applied to every patient. Every time, the core idea is simple. Assume any person could be carrying a blood-borne infection without knowing it. The older habit of ramping up caution only for patients who seem sick failed badly. Blood-borne viruses spread widely in the 1980s precisely because infected people often feel well, look well, and may not know their own status. Standard precautions close that gap by removing appearance-based guesswork entirely. The mechanism rests on consistency rather than escalation. Gloves go on for every contact with mucous membranes or fluids. Surfaces are barriered or disinfected between patients without exception. Because the protective routine never drops below a set floor, no individual judgment about a patient is needed. It is important not to confuse standard precautions with transmission-based precautions. Standard precautions are the floor that never lifts for anyone. Transmission-based precautions are extra measures added on top when a specific, highly contagious agent is identified. They build on the baseline rather than replacing it. Exam stems point to this concept with phrases like every patient, regardless of diagnosis, and treat all body fluids as potentially infectious. When you see universal, assumption-based language, standard precautions is the answer, because protection that depends on spotting a hidden danger offers no protection at all. Question 4. The exposure button is operated from. Your options are A. Right beside the tube head, B. Inside the operatory, C. Outside the room or behind a barrier, D. Under the patient chair. What's your answer? Commit to one before I continue. The correct answer is C. Outside the room or behind a barrier. C is correct because the operator activates the exposure from outside the room or behind a protective barrier, using distance and shielding to limit occupational exposure to scatter radiation during the shot. A is wrong because standing right beside the tube head places the operator in the area of greatest scatter, the opposite of the safe position the exposure switch is meant to allow. B is wrong because remaining inside the operatory beside the patient keeps the operator in the scatter field, which protection principles of distance and shielding are designed to avoid. D is wrong because the switch is not located under the chair. That position offers no shielding and would still expose the operator to scatter close to the source. When an X-ray fires, the operator's safety depends on two physical principles, distance and shielding. Together, these reduce the scattered radiation that reaches the person making the exposure. Distance works because radiation intensity drops with the square of how far you are from the source. Stepping back a few feet cuts exposure dramatically. Shielding adds a lead-lined wall or barrier that absorbs scattered photons before they reach the body. Standing outside the room delivers both effects at once. In a typical dental office, the exposure button is mounted on the wall or a cord so the operator can stand behind a lead-lined partition or step into the hallway. Scatter that does occur is either absorbed by the barrier or has thinned across the added distance before reaching the operator. Common wrong answers place the operator beside the tube head, next to the patient, or crouching under the chair, or within the denser scatter field with no barrier and minimal distance. Each ignores one or both protective effects. Unlike a patient who receives just a few images, an operator may stand near the equipment dozens of times a day for an entire career. Small repeated doses accumulate, so the guiding principle is ALARA, as low as reasonably achievable. Note that the lead apron shields the patient. The operator relies on distance and the room barrier. Question 5. Repeated scratches or wear on a PSP plate tend to produce. Your options are A. Recurring artifacts on images, B. Brighter overall contrast, C. Faster laser scanning, D. Lower patient dose. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Recurring artifacts on images. A is correct because the same plate is reused, physical scratches and wear leave marks that reappear in the same spot on image after image. So worn plates create recurring artifacts and should be replaced. B is wrong because scratches degrade the recording surface rather than enhancing it, so they cannot brighten or sharpen contrast. They add unwanted marks instead of improving the image. C is wrong because wear has no effect on how fast the laser reads the plate. Scanning speed is a property of the scanner, not of damage on the phosphor surface. D is wrong because patient dose depends on exposure settings, not on plate condition. In fact, a damaged plate may force a retake, which would raise rather than lower the dose. A photostimulable phosphor plate is a reusable image receptor that stores X-ray patterns in a delicate phosphor coating. Because it's used again and again, physical damage accumulates over time rather than resetting, and that's what makes it unique among image receptors. The phosphor layer is what captures the X-ray image, but it's soft and vulnerable. Every pass through the scanner, contact with a holder, and routine cleaning gradually wears down that surface, leaving scratches and creases that don't heal. Because a scratch sits at one fixed location on the plate, it disrupts the phosphor in exactly the same spot on every image. The artifact repeats every scan in an identical position, and it moves independently of the patient's anatomy. That stubborn consistency is the defining signature of plate wear. A common trap is assuming damage might somehow help, sharpening contrast, brightening the image, or lowering patient dose. None of these follow. Damage degrades the recording surface. Scanner speed is set by hardware, and a damaged plate that forces a retake actually increases dose. When a mark appears in the same relative position across multiple patients while the anatomy changes around it, the cause is durable damage to the phosphor plate. The correct response is to retire that plate from service before the artifact obscures real findings. Question 6. Which tissue of the tooth normally appears the most radiopaque on an image? Your options are A. Dentin, B. Pulp, C. Enamel, D. Cementum. Which would you go with? Lock it in before the reveal. The correct answer is C. Enamel. C is correct because enamel is the most mineralized tissue in the body, so it absorbs the most X-rays and appears brightest. Dentin and cementum are less dense and read slightly darker than enamel. A is wrong because dentin is mineralized but less so than enamel, giving it a slightly darker tone. It forms the bulk of the tooth beneath the brighter enamel cap. B is wrong because the pulp is soft tissue inside the canal, not a mineralized layer, so it lets X-rays pass and shows up as a dark radiolucent space rather than a bright one. D is wrong because cementum is a thin mineralized coating over the root with a density close to dentine, well below enamel, so it cannot be the densest layer the image highlights. Radiopacity describes how strongly a material absorbs X-rays and how bright it appears on a radiographic image. The denser and more mineralized a tissue is, the more of the beam it blocks, and the brighter that region looks on the image. The tooth is built from tissues of graded mineralization. Enamel forms the outer crown and is packed with mineral crystal, harder than bone. Dentin makes up the bulk beneath it, mineralized but less so. Cementum is a thin layer over the root, and the pulp at the center is living soft tissue. Ranking from most to least radiopaque, enamel is the brightest. Dentin reads a step grayer. Cementum is thin and close to dentin in density. And the pulp is soft tissue that barely attenuates the beam at all, appearing as a dark radiolucent space. The mechanism is straightforward attenuation. A heavily mineralized layer presents many dense atoms that absorb and scatter X-rays efficiently. Enamel blocks the largest share of the beam, while dentin lets a little more pass, and the pulp barely attenuates the beam at all. Remember, bright means dense and mineralized, dark means soft or demineralized. Enamel sits at the radiopaque extreme, the pulp at the radiolucent extreme, and every other tooth tissue falls somewhere on the gray scale between those two poles. Question 7. In panoramic imaging, structures positioned outside the focal trough appear. What do we translate? Your options are A. Sharper, B. Brighter, C. Larger only, D. Blurred or distorted. Don't overthink it. Which one feels right? The correct answer is D. Blurred or distorted. D is correct because only structures within the focal trough, the curved image layer matching the arch, are recorded sharply. Anything outside that zone falls out of focus and appears blurred or distorted. A is wrong because appearing sharper is the opposite of what happens. Sharpness is reserved for objects inside the trough. while those beyond it lose definition rather than gaining it. B is wrong because brightness reflects exposure and density settings, not position relative to the trough. So being outside the focal layer does not simply brighten a structure. C is wrong because structures may change size as well, but calling it larger only ignores the loss of focus. The defining result outside the trough is blur and shape distortion. Panoramic imaging sweeps a narrow beam around the head to capture the entire dental arch on one image. The key principle governing image quality is a concept called the focal trough, and understanding it explains why positioning is so critical in panoramic technique. The focal trough is a three-dimensional horseshoe-shaped zone that follows the curve of the jaws. The X-ray source and receptor rotate in coordinated motion, and only anatomy sitting within this curved band is recorded in step with the receptor's movement, producing a sharp image. Position relative to the trough determines both sharpness and apparent size. A structure inside the trough is recorded cleanly. One placed too far forward appears blurred and unnaturally narrow. One placed too far back appears blurred and artificially widened. The common result in both cases is loss of focus combined with size distortion. It is important to separate trough effects from other image quality factors. Brightness and density are controlled by exposure settings, not by where a structure sits relative to the trough. Motion blur from patient movement looks similar, but has a different cause entirely. Crucially, no structure ever gains sharpness by moving outside the focal trough. It can only lose it. The core takeaway is geometric. Inside the focal trough means sharp, and outside it means blurred and distorted, with size changes always accompanying that loss of focus. When an exam stem describes structures outside the image layer, blur and distortion together are the answer. Question 8. Under the rules for dental records, the original images are owned by the... Your options are A. Patient, B. Insurance company, C. Dentist, D. Imaging software vendor. Got a guess? Lock it in! The correct answer is C. Dentist. C is correct because although the patient pays for the service, the dentist owns the original images as part of the practice record and is responsible for retaining and safeguarding them over time. A is wrong because the patient pays for and may obtain copies of the images, but ownership of the original stays with the dentist who created and maintains the record. B is wrong because the insurance company may receive copies to process a claim, yet it never owns the patient's original dental images held by the practice. D is wrong because the software vendor supplies the imaging system but has no ownership of the clinical images themselves, which legally belong to the treating dentist of a record. Dental radiographs are part of the clinical record, and understanding who legally owns them and why is the core principle here. The answer isn't simply whoever paid or whoever is depicted. The dentist owns the original radiographs because the record serves purposes far beyond a single visit. It documents what was found and done at a specific date, supports continuity of care, enables insurance review, and provides legal defense. So responsibility for keeping it intact is fixed with the dentist. The key mechanism balancing ownership and patient interest is the distinction between originals and copies. The dentist retains the originals. The patient, a new treating dentist, or an insurer is entitled to copies, typically on a written request. The patient loses nothing diagnostic by receiving a copy. Think of the practice system as a locked archive. The original never leaves. Copies flow outward to whoever needs them, while the patient, the new provider, the insurer, while the master record stays protected in the practice. Exam writers exploit the intuitive but mistaken idea that payment or depiction confers ownership. The patient pays and is depicted, but does not own the originals. The insurer processes claims with copies. The software vendor supplied the equipment but holds no claim on the images. Payment, depiction, and equipment supply are each separate from legal ownership. Question 9. Milliamperage and exposure time are reciprocal, so raising the milliamperage lets the operator. Your options are A. Shorten the exposure time, B. Lengthen the exposure time, C. Raise the kilovoltage, D. Widen the beam. Which one is it? Pause the video if you need more time. The correct answer is A. Shorten the exposure time. A is correct because milliamperage and time are reciprocal. Increasing milliamperage allows a shorter exposure time for the same density, and the shorter time reduces the chance of motion blur from the patient. B is wrong because lengthening the time would compound the exposure rather than balance it. The reciprocal relationship means a higher milliamperage is paired with a shorter, not longer, time. C is wrong because kilovoltage is a separate factor that controls contrast and beam energy. It is not adjusted automatically by the reciprocal trade between milliamperage and time. D is wrong because beam width is set by collimation, an independent factor. Changing milliamperage affects photon output, not how wide the beam is shaped at the patient. Milliamperage and exposure time work together to control how many X-ray photons reach the receptor, which determines the overall density of the finished image. Understanding their relationship reveals a powerful tool for clinical problem solving. Milliamperage sets the rate at which photons are produced, while time sets how long that production runs. Their product determines total output, and because density depends only on that product, many different combinations of rate and time can yield the exact same result. A high milliamperage paired with a short time deposits the same number of photons as a low milliamperage over a long time. This reciprocal trade gives operators flexibility to shift between combinations without changing the final image density. The clinical payoff is sharpness. A longer exposure leaves more time for patient movement to blur the image. By raising milliamperage and proportionally shortening the time, the operator keeps density constant while narrowing the window in which motion can register. The reciprocal trade lives entirely within the density pairing of milliamperage and time. Kilovoltage governs contrast and beam energy. Collimation shapes beam width, and cone length affects distance and intensity. None of these are touched when you adjust the MA time product. Question 10. Among tissues in the dental field, which one has a fairly high sensitivity to radiation? Your options are A. Tooth enamel, B. Cortical bone, C. Dental cementum, D. The lens of the eye. Take a second. Which answer would you pick? The correct answer is D. The lens of the eye. D is correct because the lens of the eye, along with skin and oral mucosa, has a fairly high radiosensitivity and can lie within or near the field during dental imaging, which is why protection matters. A is wrong because tooth enamel is a hard, fully mineralized, non-dividing tissue, so it is essentially insensitive to radiation rather than highly responsive to it. B is wrong because cortical bone is dense, mature tissue with little cell turnover, placing it low on the sensitivity scale rather than among the more vulnerable tissues. C is wrong because dental cementum is a stable mineralized covering of the root with minimal cell division, so it is not a tissue of notably high radiosensitivity. Radiosensitivity describes how readily a tissue is damaged by radiation. Not all tissues respond equally, and the key to understanding why comes down to one principle about how cells behave. The core principle is this: cells that divide often and remain unspecialized are the most vulnerable to radiation. Cells that are mature, specialized, and rarely dividing are the most resistant. because radiation does its harm by disrupting cell division itself. Applying that principle, the lens of the eye, oral mucosa, and skin all contain actively dividing cells. Placing them on the sensitive end, enamel, cortical bone, and cementum are mineralized, mature, and non-dividing, so they sit at the resistant end. The lens of the eye contains a layer of dividing epithelial cells whose orderly arrangement maintains transparency. Radiation damage to these cells can disrupt that arrangement over time, leading to clouding, which is exactly what the dividing cell principle predicts. Whenever an exam asks which structure near the dental field is most radiosensitive, sort by cell division, the lens, mucosa, and skin divide, they are sensitive. Enamel, cortical bone, and cementum do not allow, they are resistant. That single rule resolves the ranking every time. Question 11. Before any radiographic exposure is made, the patient must first provide. Your options are A. Informed consent, B. A retainer, C. A copy fee, D. Their own apron. Before I reveal it, which one do you think is right? The correct answer is A. Informed consent. A is correct because radiation carries a small cumulative risk, so the patient must give informed consent after the procedure and its benefits are explained, which is required before exposing any images. B is wrong because a retainer is an orthodontic appliance and is actually removed before exposure to avoid artifacts. It is not something a patient provides to authorize imaging. C is wrong because a copy fee may apply only later if the patient requests duplicates of finished records. It has nothing to do with the consent needed before exposure. D is wrong because the office supplies the lead apron and thyroid collar as part of protection. The patient does not bring shielding, and shielding is not the authorization being asked about. Before any dental image is taken, the patient must give informed consent, a voluntary agreement made after the procedure. Its benefits, risks, and alternatives have been clearly explained. This isn't a formality, it's a legal and ethical precondition. Informed consent is built on a brief, honest exchange. The clinician explains why images are needed, what benefit they offer, that the dose is small but real, and that the patient may decline. Only once the patient understands and freely agrees does exposure proceed. The sequence is fixed. Explanation first, agreement documented, then and only then does the exposure happen. Consent transforms a procedure done to a patient into a shared, authorized decision. Exam questions often substitute unrelated clinical items for consent itself. The lead apron protects but does not permit. A retainer is an appliance that gets removed. A copy fee applies to duplicate records. None of these is the authorization being sought. When an exam stem asks what the patient must provide before imaging begins, the answer is informed consent. Voluntary agreement after full explanation. Shielding, appliances, and paperwork are not that agreement. Consent always comes first. Question 12. An operator should remove their personal film badge when? Your options are A. Entering the operatory, B. Having their own x-rays taken, C. Starting the work shift, D. Cleaning the treatment room. What's your answer? Commit to one before I continue. The correct answer is B. Having their own x-rays taken. B is correct because the badge measures occupational exposure only, so it is removed during the operator's own dental x-rays to avoid recording personal medical exposure as if it were work-related dose. A is wrong because entering the operatory is exactly when the badge should be worn, since that is where occupational exposure occurs and needs to be monitored. C is wrong because starting the shift is when the badge goes on, not off. because it must be in place throughout work to capture any occupational dose received. D is wrong because cleaning the treatment room is part of the work routine where the badge stays on. There is no reason to remove it for housekeeping tasks. A personal radiation badge or dosimeter has one job: to record the dose an operator receives during work. Understanding when to wear it and when to remove it comes down to a single principle. The dosimeter sits on the operator's trunk throughout every work shift, accumulating only the dose received on the job. Its record is meant to reflect occupational exposure exclusively. The moment personal medical imaging enters that record, the data is corrupted. During every work activity, entering the operatory, starting a shift, cleaning a treatment room, the badge stays on. It is removed only when the operator becomes a patient and is personally receiving X-rays. So those two types of dose never blur together. The rule is simple: badge on at the start of work, badge off only before personal imaging, and badge back on immediately after. This three-step separation keeps the occupational record clean and the operator's own medical care out of the tally. Whenever an exam stem mentions an operator having their own X-rays taken, that is the one occasion the badge must be removed. Every other work moment, the badge stays on. Question 13. To retrieve an item from a covered container mid-procedure, an acceptable aseptic method is to use. Your options are A. A bare contaminated glove. B. The patient's napkin. C. An ungloved hand. D. Sterile cotton pliers or a paper towel. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Sterile cotton pliers or a paper towel. D is correct because aseptic retrieval uses sterile cotton pliers, clean tongs, overgloves, or a paper towel to open or reach into a container. So a contaminated glove never touches the clean contents directly. A is wrong because a bare contaminated glove touching the clean contents is exactly what aseptic retrieval prevents. So it is the wrong way to reach into the container. B is wrong because the patient's napkin is not a sterile or clean retrieval aid and would itself be contaminated, so it cannot protect the contents of the container. C is wrong because an ungloved hand exposes the skin and still contaminates the contents if the hand is not clean. So it is not an acceptable aseptic retrieval method. Aseptic retrieval is the technique of removing a clean or sterile item from a covered container mid-procedure without contaminating what remains inside. The key principle is keeping a contaminated treatment glove away from clean stored supplies. Once a glove has contacted the patient's mouth, it carries organisms. Reaching into a tub of cotton rolls with that glove would contaminate every roll it touched, and every roll those touched in turn. Aseptic retrieval exists to break that chain. 3 common transfer aids keep the contaminated glove out of the supply. Sterile cotton pliers pinch and lift a single item. An overglove slips over the dirty glove to give a clean outer surface. A paper towel can grasp a handle or lift a lid. In each case, only a clean surface contacts the clean supply. The mechanism always places a clean intermediary between the contaminated glove and the clean contents. Only the transfer aid, never the glove itself, enters or opens the container, so the stored supply stays protected through the entire appointment. Exam writers often offer shortcuts that reintroduce contamination. A bare glove dipped in the container, the patient's napkin, or an ungloved hand all let a dirty surface meet a clean one, defeating the entire purpose of aseptic retrieval. Question 14. When fast electrons strike the target in the tube head, most of their energy becomes. Your options are A. Visible light, B. Useful X-rays, C. Heat, D. Sound. Which would you go with? Lock it in before the reveal. The correct answer is C, heat. C is correct because only a small fraction of the electron's energy becomes X-rays. The great majority is converted to heat at the target, which is why the tube head needs oil and metal to dissipate it. A is wrong because visible light is not the main product of the collision. The energy that does not become X-rays is released overwhelmingly as heat, not as light. B is wrong because useful X-rays make up only a small share of the output, so they cannot be the majority. The bulk of the energy is lost as heat at the target. D is wrong because sound is not produced in any meaningful amount by the electron collisions. The dominant byproduct of striking the target is heat, not acoustic energy. When electrons slam into the X-ray tube's target, their kinetic energy doesn't simply become X-rays. The conversion is surprisingly lopsided, and understanding why explains the entire cooling design of the tube head. Almost none of the electron energy produces X-rays. Roughly 99% converts to heat, and only about 1% emerges as the useful X-ray beam. Visible light and sound are not meaningfully produced at all. Most electrons make glancing contacts that simply agitate the target's atoms, generating random thermal motion, heat. Only the rare direct encounter near a nucleus or inner electron shell produces an X-ray photon. The tube head's design is a direct response to this heat problem. The tungsten target sits on a copper stem that draws heat away, and the entire tube is submerged in insulating oil that carries that heat outward to the housing, all because X-ray production generates so much more heat than radiation. Whenever an exam asks what most of the electron's energy becomes, the answer is heat, and the cooling architecture of the tube head is your proof. Question 15. A panoramic image shows a reverse, downward curving smile line with the condyles cut off. The cause is? Your options are A. The chin tip too low. B. The chin tip too high. C. The tongue not raised. D. The spine slumped forward. Don't overthink it. Which one feels right? The correct answer is B. The chin tip too high. B is correct because raising the chin too high tips the occlusal plane upward, producing a reverse downward smile line and pushing the condyles out of the image. A classic panoramic positioning error. A is wrong because tipping the chin too low produces the opposite error, an exaggerated upward smile line, so a downward reverse curve cannot come from a chin that is too low. C is wrong because failing to raise the tongue lets a dark air shadow obscure the maxillary apices. It is a separate fault that does not bend the smile line downward. D is wrong because a slumped spine can cast a radiopaque shadow over the anterior region, but it does not create the downward smile line and missing condyles described here. Panoramic image quality depends almost entirely on correct head orientation. The vertical tilt of the chin is one of the most influential variables, and each positioning mistake leaves a predictable signature on the finished image. When the chin is raised too high, the front of the occlusal plane angles upward into the beam path. This bends the normal, gentle smile curve into a downward frown, and simultaneously swings the condyles upward and outward, beyond the edges of the receptor, so the jaw joints simply disappear from the image. Every positioning fault has its own fingerprint. Chin too high gives a downward frown with missing condyles. Chin too low gives an exaggerated upward smile with lost root apices. The tongue not raised leaves a dark air shadow over the upper roots. A slumped spine casts a ghostly opacity over the front teeth. None of these mimic each other. Reading these signatures backward is the skill the exam is testing. When you see a downward curving occlusal line with both condyles cut off, the cause is a raised chin, and correcting it means reseating the patient with the chin brought back down to the standard plane. Question 16. Excessive vertical angulation of the beam causes. Your options are A. Elongation, B. Contact overlap, C. Image fog, D. Foreshortening. Got a guess? Lock it in. The correct answer is D. Foreshortening. D is correct because when vertical angulation is too steep, the projected tooth is compressed and appears too short. The error called foreshortening, which is corrected by reducing the steepness of the vertical beam angle. A is wrong because elongation arises from too little vertical angulation, the flat beam error. So excessive angulation produces the opposite shortened appearance rather than a lengthened one. B is wrong because contact overlap is a horizontal angulation problem caused by aiming the beam side to side incorrectly, not by the steepness of the vertical angle. C is wrong because image fog is a veiling loss of contrast from scatter or light, unrelated to beam angle, so it is not the result of excessive vertical angulation. When an X-ray beam is tilted too steeply downward, the resulting image of the tooth looks compressed and shorter than it really is. This error is called foreshortening, and understanding why it happens comes down to the geometry of shadows. A radiographic image is essentially a shadow. Just as a high midday sun casts a short shadow of a standing pole, a beam angled too steeply against a tooth throws a compressed shadow onto the receptor. The tooth appears stubbier than it truly is. When the beam crosses too perpendicular to the tooth's long axis, the vertical dimension collapses on the image. Ease the beam to the correct angle and the recorded lens stretches back to match reality. 4 errors are commonly confused. Too much vertical angulation gives foreshortening. Too little gives elongation. Horizontal angulation errors cause contact overlap, not length distortion. Fog is a contrast problem from scatter and has nothing to do with beam angle. When exam stems describe teeth that appear too short and ask for the cause, think steep beam and foreshortening. The fix is always to reduce the vertical angulation until the beam meets the tooth and receptor in the correct geometric relationship. Question 17. A common exam trap is to wrongly label which agency as a regulatory fine issuing body. Your options are A. The CDC, B. OSHA, C. The FDA, D. The EPA. Which one is it? Pause the video if you need more time. The correct answer is A. The CDC. A is correct because the CDC is frequently mislabeled as a regulatory agency, but it only recommends. It sets the scientific standard of care, while OSHA, the FDA, and the EPA hold the actual regulatory authority. B is wrong because OSHA genuinely is a regulatory agency that enforces safety law and issues fines, so naming it is correct rather than the trap the question is pointing to. C is wrong because the FDA truly regulates by clearing medical devices and drugs, so it is an actual regulator, not the agency students mistakenly elevate to enforcement power. D is wrong because the EPA really does regulate, registering disinfectants and overseeing hazardous waste, so it is a legitimate regulator and not the misremembered advisory body. Federal health agencies split into 2 distinct roles: those that recommend best practices and those that actually regulate through law. Understanding this divide is essential because the exam tests whether you can tell them apart. The CDC studies disease, investigates outbreaks, and publishes infection control guidance that defines the standard of care, but it has no legal authority. It cannot inspect officers, write enforceable law, or impose fines. Its power is scientific credibility, not legal force. The true regulators each carry the force of law. OSHA enforces workplace safety. The FDA clears medical devices and drugs, and the EPA oversees disinfectants and hazardous waste. All 3 can inspect facilities and levy penalties, something the CDC simply cannot do. In practice, a dental office builds its protocol around CDC guidance, which defines the expected standard of care. But when an inspector arrives with authority to levy penalties, that inspector represents OSHA, not the CDC. The advice and the enforcement travel through two entirely separate channels. Exam stems exploit how authoritative CDC guidance feels. It can seem like law. When a question asks which agency is wrongly labeled a fine issuing regulator, the answer is always the recommending body. Sought advice from enforcement and the trap disappears. Question 18. Digital image enhancement software is limited because it cannot. Your options are A. Adjust brightness, B. Flip the image, C. Create missing information, D. Measure distances. Take a second. Which answer would you pick? The correct answer is C. Create missing information. C is correct because software can only work with the data that was actually captured, so it cannot create information that was never recorded. A grossly underexposed or mispositioned image still needs a retake. A is wrong because adjusting brightness is a routine. Legitimate enhancement the software performs well. The real limitation is that it cannot manufacture detail that exposure never captured. B is wrong because flipping or rotating an image is a simple display function within the software's ability, not the boundary. The boundary is recovering data that was never there. D is wrong because measuring distances is a standard tool in digital systems and works fine. The genuine limit is that no measurement or filter can replace uncaptured information. Digital enhancement software is a powerful tool, but it has one hard limit that never bends. It can only work with the data the receptor actually recorded. No algorithm can manufacture information that was never captured in the first place. Brightness adjustments rescale existing values. Contrast stretches the spread of recorded tones. Sharpening accentuates edges already in the data. Flipping, rotating, and measuring all operate on real captured information. Each of these is a transformation, not a creation. Imagine a periapical where the receptor was placed too shallow and the root apex fell outside the recorded area. No brightness change, no sharpening filter, no processing of any kind can place that apex on the image, because the apex was simply never captured. Software can only reveal what is faintly present. It cannot conjure what is entirely absent. If a region recorded no meaningful signal, there is no underlying value for any algorithm to enhance. The exam tests exactly this distinction. Brightness, flipping, and measurement are all genuine capabilities the software performs well. The single thing it cannot do is invent data that was never recorded. When detail is missing, the only remedy is a retake. Question 19. Dental images should be prescribed by patient need under selection criteria rather than. Your options are A. On a fixed routine schedule, B. Only when the patient asks, C. By the assistant's preference, D. Based on the calendar date. Before I reveal it, which one do you think is right? The correct answer is A. On a fixed routine schedule. A is correct because selection criteria individualize imaging by each patient's carries risk and clinical need. So radiographs are ordered for a specific clinical reason rather than automatically on a fixed routine schedule. B is wrong because imaging is not driven by patient request. The dentist prescribes based on clinical need and selection criteria, not simply on whether a patient asks. C is wrong because the assistant exposes images but does not decide when they are needed. That judgment belongs to the dentist applying selection criteria, not personal preference. D is wrong because the calendar date alone is just another form of fixed routine prescribing, which selection criteria are meant to replace with individualized, need-based decisions. Selection criteria are professional guidelines that individualize radiograph prescribing based on each patient's actual clinical need, not a fixed routine schedule. The core principle is simple. Every exposure must be justified by a specific clinical reason. Clinical judgment draws on the full picture of the individual. Symptoms, carries risk, restoration history, and periodontal status. From that evidence, images are ordered only where they will actually inform care, not because the calendar says so. Consider 2 patients seen the same week. The high-risk patient with recent lesions is imaged sooner because the evidence justifies it. The stable, low-risk patient waits longer because nothing clinical calls for imaging now. Same office, different intervals, each set by need. The exam tests whether you can spot the wrong triggers, a routine schedule, a fixed calendar date, a patient request, or an assistant's preference. Each one removes individualized clinical judgment from the decision, and that judgment belongs to the dentist alone. Selection criteria keep radiation exposure aligned with benefit. When the exam asks what radiograph prescribing should be based on, the answer is always the individual patient's clinical need, never automatic scheduling. Question 20. When removing a barrier from a contaminated receptor, the operator should first. Your options are A. Scan the plate. B. Remove both gloves. C. Decontaminate the outer barrier. D. Expose another image. What's your answer? Commit to one before I continue. The correct answer is C. Decontaminate the outer barrier. C is correct because the outer barrier is contaminated, so it is wiped or decontaminated before being opened, which keeps the inner receptor clean as it is removed for scanning or reuse. A is wrong because scanning the plate before handling the barrier risks carrying contamination to the scanner. The contaminated outer barrier is dealt with first, not the plate. B is wrong because removing gloves first leaves bare hands to handle a contaminated barrier, so the operator stays gloved and decontaminates the outer barrier before opening it. D is wrong because exposing another image has nothing to do with safe barrier removal. The immediate task is to wipe down the contaminated outer barrier before it is removed. After a barrier-protected receptor is removed from the patient's mouth, its outer surface is contaminated. Understanding why the removal sequence matters is the key concept being tested here. The barrier did its job during exposure. The outer surface contacted saliva while the receptor inside remained clean. That distinction between the contaminated exterior and the clean interior is exactly what the safe sequence is designed to protect. The correct order has 3 steps. First, decontaminate or carefully handle the outer barrier. Second, peel it back so the clean receptor drops into a clean field without touching the dirty surface. And third, discard the pouch and proceed to scanning. Each wrong approach fails for the same reason. Contamination travels by contact. Skipping or reversing the sequence allows the dirty outer surface to reach either the clean plate, the scanner, or the operator's hands, completing the chain of transfer that the barrier was meant to prevent. When an exam stem asks what the operator should do first after removing a barrier-protected receptor, the answer is always to deal with the contaminated outer surface before anything else. That one deliberate step keeps the clean plate clean and the workflow safe. Question 21. Ionization is best described as the process of Your options are A. Joining 2 atoms together. B. Emitting visible light. C. Heating a molecule. D. Removing an electron from an atom. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Removing an electron from an atom. D is correct because ionization removes an electron from a neutral atom, leaving a positive ion and a freed negative electron. This charged, unstable pair is what goes on to disrupt cellular metabolism. A is wrong because joining atoms describes bonding or fusion, the opposite of ionization, which destabilizes a single atom by stripping an electron rather than uniting two atoms. B is wrong because emitting visible light is fluorescence or luminescence, an energy release that does not involve knocking an electron loose, so it is not ionization. C is wrong because heating a molecule adds thermal energy and increases motion, but it does not by itself eject an electron, so warming is not the same as ionizing. When we talk about why X-rays are dangerous, it all comes down to one fundamental event, ionization. Understanding exactly what ionization is and what it is not explains how radiation causes biological harm. The process unfolds in a single chain reaction. An X-ray photon transfers its energy to an orbital electron, and if that energy exceeds the electron's binding force, the electron is ejected. The atom is now a positively charged ion, and the freed electron often carries enough energy to ionize neighboring atoms in turn. Inside living tissue, this plays out around water molecules. A photon ejects an electron from a water molecule, leaving a reactive charged fragment. That fragment attacks neighboring molecules, including genetic material, setting a small cascade of chemical injury in motion long after the original photon is gone. Ionization is easy to confuse with other things energy can do to matter. Bonding joins atoms together, the opposite of destabilizing one. Fluorescence releases energy as visible light without ejecting any electron. Heating raises thermal motion but does not knock electrons loose. Only electron removal is ionization. Every rule about limiting radiation dose traces back to this single event. Ionization, the stripping of an electron from a neutral atom, is what makes X-rays capable of disrupting the molecules of life. Keep that definition narrow and exact, and the distractors on any exam become easy to dismiss. Question 20. Unlike the inflammatory apical lesions, condensing osteitis appears on the image as. Your options are A widened canal, B a radiopaque area, C a dark apical halo, D a fractured root. Which would you go with? Lock it in before the reveal. The correct answer is B, a radiopaque area. B is correct because condensing osteitis is added bone density, a reaction to chronic low-grade pulpal irritation. So it shows as a radiopaque area near the apex rather than the radiolucency of bone destruction. A is wrong because a widened canal suggests internal resorption ballooning the pulp space from inside, a different process that darkens the canal rather than laying down the dense bone seen here. C is wrong because a dark apical halo describes the radiolucency of an abscess, granuloma, or cyst. Condensing osteitis is the opposite, gaining bone instead of losing it at the root tip. D is wrong because a fractured root shows as a radiolucent line crossing the root, a mechanical break, not the localized increase in bone density that defines condensing osteitis. Condensing osteitis is the body's sclerotic answer to chronic, low-grade pulpal irritation, and it behaves in the opposite way from every other apical lesion you'll encounter. When irritation at the root tip is severe, the body destroys bone, creating a dark radiolucency. But when that irritation is mild and long-lasting, some bone instead becomes denser and more sclerotic. That sclerotic reaction is condensing osteitis. On a radiograph, that dense deposit absorbs more of the X-ray beam than surrounding bone, casting a bright radiopaque patch at the root tip. The more mineralized the deposit, the wider it appears. Every other common apical finding, granulomas, cysts, abscesses, and root fractures, destroys bone and darkens the image. Condensing osteitis stands alone as the one that adds bone and brightens it. When an exam stem contrasts a radiopaque apical area with the usual dark inflammatory lesions, it is testing exactly this reversal. Chronic mild irritation drives bone deposition, not destruction, and that deposited bone is what makes condensing osteitis uniquely bright. Question 23. Mask and protective eyewear are specifically indicated when your options are A. The room is dim, B. The patient is calm, C. Spatter or coughing is anticipated, D. The gloves are torn. Don't overthink it. Which one feels right? The correct answer is C. Spatter or coughing is anticipated. C is correct because A. Mask and protective eyewear guard the face and eyes from spray and spatter, so they are indicated whenever spatter is anticipated, such as with a coughing or gagging patient. A is wrong because dim lighting is addressed by adjusting the lights, not by facial protection, so it is not what triggers the use of a mask and eyewear. B is wrong because a calm patient lowers the chance of spatter, which would reduce rather than create the need for mask and eyewear. So this reverses the indication. D is wrong because torn gloves call for replacing the gloves. The issue is hand protection, not the facial barrier that a mask and protective eyewear provide. Masks and protective eyewear are personal protective equipment designed to shield the face during patient care. Understanding exactly when they are indicated and why is the core principle being tested. The eyes, nose, and mouth are open portals through which infectious organisms can enter the body. Blood, saliva, and respiratory secretions carried in droplets can land on these surfaces and bypass the skin's protective barrier entirely. The mechanism is simple physical interception. The mask blocks droplets from reaching the lips and respiratory openings, while eyewear stands between flying spatter and the eyes. Together they form a continuous barrier across the most vulnerable facial surfaces. The key indicator is anticipated spatter reaching the face, a patient with a strong gag reflex, coughing during care, or a procedure that generates spray. These are all conditions where contaminated droplets are most likely to reach facial mucosa or the eyes. A dim room is fixed with lighting adjustments, not facial protection. A calm patient reduces spatter risk rather than creating it. Torn gloves call for new gloves. That is a hand protection problem, not a facial one. The defining trigger for a mask and eyewear is anticipated spatter, full stop. Question 24. Which receptor size is typically used for an adult occlusal image? Your options are A. Size 4, B. Size 0, C. Size 1, D. Size 2. Got a guess? Lock it in. The correct answer is A. Size 4. A is correct because the adult occlusal uses the large size 4 receptor, which the patient bites to hold flat, so it can capture a broad section of the palate or floor of the mouth in one image. B is wrong because size 0 is the smallest receptor, made for young children's small mouths and anterior placement. Far too little coverage for an adult occlusal survey of the USH. C is wrong because size 1 is a narrow receptor used for adult anterior intraoral views. It lacks the breadth needed to image a whole arch segment from the biting plane. D is wrong because size 2 is the standard intraoral size for periapicals and bite wings, not the larger plate the patient bites to obtain a broad occlusal projection. Intraoral receptors come in a graded series of sizes, each matched to a specific clinical task. Understanding why size 4 is reserved for adult occlusal imaging comes down to one principle: the job demands breadth. Size 0 is the smallest, made for children's mouths. Size 1 handles adult anterior views. Size 2 is the everyday posterior periapical and bite-wing plate. Size 4 stands apart as the largest, the broad occlusal receptor. The size 4 plate is placed flat across the occlusal plane, and the patient bites lightly to hold it steady and parallel to the arch. The beam is directed from above for a maxillary occlusal or from below for a mandibular one. Where most intraoral images focus on a few teeth, the occlusal projection surveys an entire arch segment from above or below. This wide field, useful for locating impactions, salivary stones, and lesion extent, is exactly why the largest plate is required. Whenever an exam stem mentions the adult occlusal image, the large plate the patient bites, or broad coverage of the palate or floor of the mouth, size 4 is the answer being tested. Question 25. During an exposure, the operator should never hold. Your options are A. The control panel, B. The receptor in the mouth, C. The lead apron, D. The patient's chart. Which one is it? Pause the video if you need more time. The correct answer is B. The receptor in the mouth. B is correct because holding a receptor in the patient's mouth places the operator's hand in the primary beam and repeats that exposure daily. So this is never done. A holder or shielded caregiver is used instead. A is wrong because the control panel is where the operator stands to set factors and initiate the exposure from safety. Touching it is normal and carries no extra radiation risk. C is wrong because the lead apron is draped on the patient before exposure and is not held during the shot. Handling it beforehand is routine and poses no beam exposure. D is wrong because the patient's chart is reviewed before imaging and kept away from the field. It is not held in the beam, so it is not the hazard being warned against. A fundamental rule in dental radiography is that the operator must never hold the receptor inside a patient's mouth during an exposure. Understanding why this rule exists and what to do instead is the core of radiation protection for dental staff. The primary beam is the most intense radiation the machine produces. Unlike a patient who is exposed only occasionally, an operator holding receptors would intercept the primary beam at every single exposure, accumulating dose throughout an entire career. The ALARA principle, keeping dose as low as reasonably achievable, makes routine primary beam exposure completely unacceptable. A receptor holding device grips the sensor or plate and stabilizes it in the correct position without any fingers entering the radiation field. The operator stands safely at the control panel. The holder does the work the hand must never do. When a patient genuinely cannot manage a holder, such as a young child, a non-occupationally exposed adult like a guardian may assist while wearing protective shielding and positioned to avoid the beam. The operator, who would otherwise repeat this exposure endlessly across a career, must always stay out of the primary beam. The exam tests whether you can separate the one forbidden act from routine safe tasks. The control panel, the lead apron, and the patient chart are all handled without entering the beam. Only holding the receptor inside the patient's mouth during exposure places a hand directly in the primary beam, and that is the single act the operator must never perform. Question 26. An extra tooth located in the maxillary midline between the central incisors is A. Your options are A. Peg lateral, B. Geminated tooth, C. Fused tooth, D. Meschudens. Take a second. Which answer would you pick? The correct answer is D. Meschudens. D is correct because a meschudens is a supernumerary tooth that sits in the maxillary midline between the central incisors, often blocking or deflecting their eruption, and is the most common extra tooth. A is wrong because a peg lateral is a small, cone-shaped lateral incisor an anomaly of shape rather than an extra tooth, and it occupies the normal lateral position, not the midline. B is wrong because a geminated tooth comes from one bud trying to split, producing a single large tooth. It adds bulk, not an additional tooth, and is not specific to the midline. C is wrong because a fused tooth results when two buds join into one, which lowers the count rather than adding a separate extra tooth wedged between the central incisors. A mesiodens is the most common supernumerary tooth in the mouth, a yeshit, wasiwe colt, an extra tooth that forms in the maxillary midline, wedged between the two upper central incisors. On a radiograph, the mesiodens appears as a separate, often conical tooth positioned between or above the central incisors. Because it occupies the eruption path, it can physically obstruct or deflect the permanent incisors as they try to come in. Clinically, a mesiodens left in place blocks central incisor eruption, rotates or crowds adjacent teeth, and creates spacing problems that show up early in a child's dentition. Removal typically allows the held back incisor to erupt normally. The key distinction is what each anomaly does to tooth number and form. A mesiodens adds a whole extra tooth in the midline. A peg lateral merely reshapes a normally placed tooth. Gemination splits one bud into a single enlarged tooth, while fusion merges two buds into one, actually reducing the count. Question 27. Which agency issues enforceable workplace safety regulations such as the bloodborne pathogens standard? Your options are A. OSHA, B. CDC, C. ADA, D. EP. Before I reveal it, which one do you think is right? The correct answer is A. OSHA. A is correct because OSHA is the regulatory body that writes and enforces workplace safety law, including the bloodborne pathogen standard, and it can inspect officers and levy fines for non-compliance with those rules. B is wrong because the CDC studies disease and issues infection control recommendations that become the standard of care, but it does not write enforceable law or impose fines on a dental office. C is wrong because the ADA is a professional association that advises dentists and publishes guidance. It has no authority to regulate workplaces or enforce safety standards with penalties. D is wrong because the EPA registers surface disinfectants and oversees hazardous waste, but it does not issue the workplace bloodborne pathogen rules that govern protecting employees. OSHA is the federal body that writes and enforces workplace safety law, not just recommends it. That legal authority is what sets it apart from every other agency that touches dental practice. The mechanism runs through 3 steps. OSHA issues a standard spelling out what employers must do. Employers are legally bound to comply, and inspectors can then examine the workplace and levy fines for any gaps. The bloodborne pathogens standard is OSHA's clearest example in dentistry, converting infection control principles into 4 concrete legal obligations: an exposure control plan, personal protective equipment, staff training, and offering the hepatitis B vaccine. The confusable agencies each play a different role. The CDC studies disease and issues recommendations. The ADA publishes guidance for members. The EPA oversees disinfectants and hazardous waste. Only OSHA can inspect an office and impose monetary penalties for non-compliance. When an exam stem mentions the bloodborne pathogens standard, inspections, or fines, the answer is OSHA. Recommendations protect no one on their own. Enforceable standards backed by penalties do. Question 28. Because neither sensors nor PSP plates can be heat sterilized, each patient requires. Your options are A. A new lead apron, B. A longer PID, C. A fresh barrier on the receptor, D. A higher kilovoltage. What's your answer? Commit to one before I continue. The correct answer is C. A fresh barrier on the receptor. C is correct because digital receptors cannot withstand heat sterilization. So a fresh disposable barrier is placed over the sensor or plate for every patient to prevent cross-contamination during the procedure. A is wrong because the lead apron is wiped and reused as patient shielding, and is not the infection control answer here. The receptor itself is what needs a fresh barrier each time. B is wrong because a longer PID is a dose-reducing geometry choice, unrelated to infection control, so it does nothing to address the receptor that cannot be heat sterilized. D is wrong because color voltage governs image contrast and has no bearing on preventing cross-contamination, so changing it does not substitute for barrier protection of the receptor. Digital image receptors, both solid-state sensors and phosphoplates, cannot survive the heat of an autoclave, so infection control for these devices relies on a completely different strategy. Metal instruments can be autoclaved between every patient, killing all organisms, but a receptor packed with circuitry or coated with sensitive phosphor cannot survive that heat even once. So the gold standard decontamination method is simply off the table. The solution is a disposable barrier, a fresh plastic sheath placed over the receptor before each patient. It intercepts saliva and contact, so the receptor itself stays shielded. After imaging, the contaminated barrier is peeled off and discarded. Common distractors target other concerns entirely. A new lead apron addresses patient shielding. A longer cone reduces dose geometry, and higher kilovoltage adjusts contrast. None of these touches receptor contamination. Only the fresh barrier solves the problem the exam is testing. The receptor cannot be sterilized, so a barrier steps in where sterilization would otherwise belong, with disinfection as a backup in case of leaks. Linking the receptor's heat sensitivity to the barrier solution is exactly the concept being tested. Question 29. In radiographic localization, the SLOB rule stands for. Your options are A. Straight lingual, opposite base. B. Same lingual, opposite buccal. C. Side lingual, outer bone. D. Set level of bone. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Same lingual, opposite buccal. B is correct because SLOB means same lingual, opposite buccal. When the tube is shifted, an object moving the same way as the beam lies lingual, and one moving the opposite way lies buccal. A is wrong because straight lingual, opposite base is not the phrase. The second word must be buccal, since the rule contrasts the lingual and buccal sides, not a base. C is wrong because side lingual, outer bone, misstates the rule. The memory aid pairs lingual with same and buccal with opposite, not vague terms like side and outer bone. D is wrong because set, level of bone has nothing to do with the rule. A SLOB is about left-right object movement with a tube shift, not about measuring bone height. The SLOB rule is a classic localization technique used when a flat radiograph can't reveal depth. By taking two images with the X-ray tube shifted between them, we can determine whether an object lies toward the tongue or toward the cheek. A single radiograph collapses 3 dimensions into a flat shadow. You can see an object near a tooth, but not whether it's buccal or lingual. Shifting the tube between two exposures creates a parallax effect that recovers that missing dimension. When the tube moves in a known direction, objects on the lingual side appear to shift the same way, while objects on the buccal side appear to shift the opposite way. This differential movement is the parallax the SLOB rule exploits. The rule is simple. Same direction as a tube shift means lingual. Opposite direction means buccal. The entire value of this technique lies in remembering the exact pairing. Any swap or vague substitute renders the rule useless. When an exam stem asks what SLOB stands for or how to locate a shifted object, Recall this pairing exactly. Same movement is always lingual. Opposite movement is always buccal. No exceptions, no substitutions. Question 30. The exposure factor that primarily controls the contrast of an image is. Your options are A. Milliamperage, B. Exposure time, C. PID length, D. Kilovoltage. Which would you go with? Lock it in before the reveal. The correct answer is D. Kilovoltage. D is correct because color voltage is the primary control of contrast, because it sets the energy of the beam and how differently tissues absorb it, which determines the range of grays recorded on the image. A is wrong because milliamperage governs the quantity of photons and therefore density, not the tonal range. Raising it darkens the image rather than changing its contrast. B is wrong because exposure time works with milliamperage to set density. Together they control darkness, leaving image contrast to be determined chiefly by the kilovoltage setting instead. C is wrong because PID length affects magnification and intensity through distance, but it is not the factor that establishes the contrast or grayscale of the recorded image. Kilovoltage is the exposure factor that sets the energy and penetrating power of the X-ray beam, making it the primary control of image contrast. Contrast is the range of gray tones, how sharply light areas differ from dark ones. Understanding why kilovoltage owns contrast comes down to how beam energy drives differential absorption through tissue. Contrast depends on differential absorption, how differently tissues absorb the beam. Because kilovoltage controls photon energy, it directly governs how unevenly those photons are absorbed across anatomy, reshaping the grayscale with every adjustment. A higher kilovoltage produces a more penetrating beam that passes through dense and less dense tissues more uniformly, yielding a long grayscale with many subtle shades. That is low contrast. A lower kilovoltage sharpens absorption differences between tissues, producing a short grayscale of fewer, bolder tones. High contrast. Turning kilovoltage up or down slides the image along that entire range. The key distinction for exams is separating contrast controls from density controls. Milliamperage and exposure time set overall image darkness, not the range of grays. Cone length affects magnification and intensity through distance. Kilovoltage alone sets beam energy and therefore stands as the sole primary control of contrast. When an exam stem asks which factor primarily controls contrast or sets the range of grays, the answer is kilovoltage. It governs beam energy, differential absorption, and the full grayscale, while milliamperage and time stay paired with density. Question 31. Which receptor size is standard for adult posterior periapicals and bite wings? Your options are A size 2, B size 0, C size 4, D size 3. Don't overthink it. Which one feels right? The correct answer is A, size 2. A is correct because size 2 is the standard receptor for adult posterior periapicals and bite wings, large enough to capture the back teeth while still fitting comfortably in the typical adult mouth. B is wrong because size 0 is the smallest receptor intended for small children and primary teeth, so it is too little coverage for adult posterior work. C is wrong because size 4 is the larger occlusal plate the patient bites. It is far too big for routine posterior periapicals or bite wings in an adult. D is wrong because size 3 is a long, narrow bite wing receptor for a single elongated view, not the standard size used across adult posterior periapicals and bite wings. In dental radiography, not all intraoral receptors are the same size. Each is designed for a specific patient population and tooth region. SARS 2 is the workhorse of the series, and understanding why it became the default for adult posterior imaging starts with the anatomy it has to cover. Place for a posterior periapical. SARS 2 spans both the molar and premolar, capturing the full length of each tooth from crown to root tip along with the crestal bone between them. Turn for a bite wing. That same plate records the crowns of upper and lower posterior teeth, ideal for detecting interproximal decay. SARS 2 sits at the center of a purpose-built series. SARS 0 is made for young children and primary teeth. SARS 1 handles adult anterior views. And SARS 4 is the large occlusal plate the patient bites. Each SARS serves a narrower role. Only SARS 2 covers routine adult posterior periapicals and bite wings. The reason SARS 2 became the default is simple geometry. It is large enough to record a molar and premolar together with their roots and surrounding bone in a single exposure, yet small enough to seat comfortably without bending or gagging the patient. That practical compromise made it the standard. Whenever an exam stem asks about the standard receptor for adult posterior periapicals or bite wings, SARS 2 is the answer. Its dimensions suit both tasks across the entire posterior segment, making it the single most used receptor in a general dental practice. Question 32. Which device with ear rod standardizes head position for a cephalometric image? Your options are A. Bite block, B. Cephalostat, C. Position indicating device, D. Receptor holder. Got a guess? Lock it in. The correct answer is B. Cephalostat. B is correct because the cephalostat uses ear rods seated in the ear canals to fix the head in a reproducible position, so serial cephalometric images can be compared accurately over a course of treatment. A is wrong because a bite block stabilizes a receptor inside the mouth for intraoral views. It does not orient the whole head the way the cephalostat does for an extraoral projection. C is wrong because a position indicating device aims and shapes the X-ray beam from the tube head. It directs radiation rather than holding the patient's head in a fixed cephalometric pose. D is wrong because a receptor holder grips an intraoral sensor or plate in place. It has no role in standardizing skull orientation for a reproducible cephalometric measurement. The cephalostat is the device behind cephalometric imaging, a skull profile X-ray used to track jaw and tooth movement across orthodontic treatment. Understanding why it exists means understanding why reproducibility matters so much in this kind of imaging. The ear rods seat inside the external ear canals on both sides of the head, locking the skull at two fixed bony landmarks. A nasal support then orients the face to a standard reference plane, so the source to patient and patient to receptor relationships stay identical from one visit to the next. Because cephalometric care tracks jaw growth and tooth movement over months, every image in the series must be taken from the same vantage. A fixed head pose produces comparable images, so only true skeletal and dental changes appear, not artifacts from a tilted or shifted head position. The exam pairs the cephalostat against three confusable devices. A bite block and a receptor holder both stabilize a receptor inside the mouth. The cone or position indicating device directs and shapes the radiation beam. None of these orient the entire skull. That role belongs exclusively to the cephalostat. When an exam stem mentions ear rods, a skull profile image, or reproducible head orientation, the answer is always the cephalostat. It is the only device that locks the entire skull in place, so cephalometric images can be meaningfully superimposed and compared over time. Question 33. In a common color-coded holder system, the red components are used for. Your options are A. Anterior periapicals, B. Occlusal images, C. Panoramic setup, D. Bite wings. Which one is it? Pause the video if you need more time. The correct answer is D, bite wings. D is correct because in the familiar color scheme, blue holders are for anterior periapicals, yellow for posterior periapicals, and red for bite wings. So red identifies the bite wing assembly the operator reaches for. A is wrong because anterior periapicals use the blue holder components in this color system, not the red ones. So red would direct the operator to the wrong assembly for that view. B is wrong because occlusal images have the patient bite a large receptor and do not rely on the color-coded periapical and bite wing holders. So red does not designate an occlusal setup. C is wrong because panoramic imaging uses no intraoral holder at all, since the receptor rotates outside the mouth. So the red bite wing components have no role in a panoramic exposure. Receptor holder systems use color coding so operators can instantly grab the right assembly for each view. Every color corresponds to a specific radiographic technique, keeping setup fast and accurate. In the standard scheme, blue marks anterior periapicals, yellow marks posterior periapicals, and red marks the bite wing assembly. Occlusal and panoramic imaging fall completely outside this color-coded system. Each color groups 3 components: a bite block, an indicator arm, and an aiming ring. The red set is configured specifically for bite wing geometry, positioning the receptor to capture the crowns of upper and lower posterior teeth simultaneously. The 3 red components snap together into a single unit. Because all pieces share the same color, the operator can confirm at a glance that the assembly is complete and correctly matched before positioning the patient. When an exam stem asks which view uses the red holder components, the answer is bite wings. Keep each color locked to its view. Blue for anterior periapicals, yellow for posterior periapicals, and red for bite wings. And the color coding questions become automatic. Question 34. Which projection is specifically listed for locating retained roots and impacted teeth? Your options are A. Beats 1, B. Panoramic only, C. Occlusal projection, D. Cephalometric. Take a second. Which answer would you pick? The correct answer is C. Occlusal projection. C is correct because the occlusal, or right angle, projection is the source-listed view for locating retained roots, impacted teeth, salivary stones, and fractures over a broad section of an arch. A is wrong because a bite wing is built for interproximal caries and crestal bone on a few teeth. Its small field is not the projection name for locating retained roots in the bone. B is wrong because the panoramic surveys broadly and helps spot impactions, but the specific source-listed localization view for retained roots and impacted teeth is the occlusal, not the panoramic alone. D is wrong because acephalometric is an extraoral orthodontic projection of the skull profile. It is not used to pinpoint retained roots or impactions within the dental arch. The occlusal projection is the go-to view when a clinician needs to survey a broad section of the jaw to find something hidden: a retained root, an impacted tooth, a salivary stone, or a fracture line. The patient bites down on a large receptor that spans an arch segment, and the beam is aimed roughly perpendicular to it, either downward onto the maxilla or upward onto the mandible, producing a wide footprint image unlike standard side-on intraoral views. This broad coverage makes the occlusal projection the specifically named view for 4 localization tasks: retained roots, impacted teeth, salivary stones, and fractures spread across the arch. Other projections are built for different jobs. A bite wing targets decay on a few teeth. A panoramic surveys broadly but is not the named localization view. And a cephalometric image profiles the skull for orthodontics, None of them owns the retained root and impaction localization role. Whenever an exam stem asks which projection is used to find retained roots, impactions, or salivary stones across a wide arch area, the answer is the occlusal projection. Its large receptor and perpendicular beam give the broad survey that task demands. Question 35. To reduce gagging, the periapical exposure sequence usually begins with the... Your options are A. Anterior teeth, B. Maxillary molars, C. Mandibular molars, D. Premolars. Before I reveal it, which one do you think is right? The correct answer is A. Anterior teeth. A is correct because starting with the anterior teeth eases the patient into the procedure and provokes the least gagging. So the sequence works front to back and saves the gag-prone areas for later. B is wrong because maxillary molars are the most likely to trigger gagging. So they are saved for last and a strong gagger, never used to open the sequence. C is wrong because mandibular molars sit deep in the back of the mouth and are more likely to provoke gagging than the front teeth. So they do not begin the series. D is wrong because premolars fall between the anterior and molar regions and come after the anteriors. Beginning with them skips the gentler anterior start that reduces gagging. When taking a full series of periapical images, the order in which you place the receptor matters, especially for patients with a sensitive gag reflex. The key principle is a simple front-to-back sequence. The sequence starts with the anterior teeth, moves to the premolars, and finishes with the molars. This progression matches rising gag sensitivity. The front provokes almost no gag reflex, while the upper molars are the most provocative area of all. The gag reflex is triggered when the receptor contacts sensitive tissues at the back of the palate and throat. Anterior placements sit far from these zones, so patients tolerate them easily. Posterior placements, especially upper molars, sit closest to the trigger zone. Starting at the front works because both the physical reflex and the patient's anxiety ease with a gentle opening. By the time the operator reaches the upper molars, the single most gag-prone region, Said says, the patient has found a rhythm and is far better prepared to tolerate them. Question 36. Because a barrier can leak, a digital sensor should also be... Your options are A. Left uncovered next time, B. Cleaned and disinfected between patients, C. Heat sterilized weekly, D. Soaked overnight. What's your answer? Commit to one before I continue. The correct answer is B. Cleaned and disinfected between patients. B is correct because barriers reduce but do not eliminate contamination. So even a barriered sensor is cleaned and disinfected between patients with a compatible product, following the manufacturer's instructions for that specific device. A is wrong because leaving the sensor uncovered would remove the first line of protection entirely. The lesson from leaks is to add disinfection, not to abandon the barrier. C is wrong because weekly heat sterilization would destroy the sensor and would not address day-to-day contamination, so it is neither safe nor the recommended routine. D is wrong because soaking the sensor overnight immerses electronics that immersion ruins, so it is not an acceptable way to handle a receptor whose barrier may have leaked. Because a barrier can leak, relying on it alone isn't enough. Infection control for digital sensors requires 2 layers working together, not just one, to protect every patient. Between every patient, the sequence is always the same. Remove and discard the used barrier. Wipe the sensor with a manufacturer-approved disinfectant and let it act for the directed time. Then apply a fresh barrier before the next patient. This belt and suspenders approach exists because sheaths can tear, leak at a seam, or be breached during handling. Routine disinfection ensures that a small barrier failure never becomes a failure of infection control. The disinfectant used must be one the manufacturer approves. The wrong chemical can damage the sensor surfaces or electronics. The device must never be heat sterilized or soaked, as immersion and high heat will ruin it. When a STEM tells you a barrier can leak and asks what else is needed, the answer is cleaning and disinfection with a compatible product, keeping the barrier two. 2 layers, not one, is the principle the exam rewards. Question 37. When a patient requests their dental images, the office should provide. Your options are A. The original films, B. Nothing without payment, C. Only verbal results, D. Copies on written request. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Copies on written request. D is correct because the dental record stays with the practice, so the office releases copies rather than originals, and only after the patient submits a written request authorizing the transfer of the records. A is wrong because the original images are part of the legal record the dentist must retain, so they are never handed over. The patient receives duplicates instead. B is wrong because records cannot be withheld simply over a balance. A proper written request must be honored with copies, kept separate from any outstanding billing dispute. C is wrong because verbal results alone do not satisfy a request for the images themselves. The patient is entitled to copies of the actual records upon written authorization. When a patient requests their dental images, the office doesn't simply hand over everything in the file. There's a specific protocol that protects both the patient's right of access and the practice's legal obligations. The process has 3 steps. The patient submits a written request. The office prepares duplicate copies of the images, and those copies go to the patient or their new provider. The written request creates a documented record of who authorized the release and where the records went. The originals never leave the practice. They are part of the legal record the dentist is obligated to retain for the required retention period. With digital imaging, a copy is diagnostically identical to the original, so the patient loses nothing by receiving one. Exam writers test 3 wrong approaches: surrendering the original films, which abandons the legal record, withholding records over an unpaid balance, which improperly denies access, and offering only verbal results, which falls short of the images the patient is entitled to. Only copies released on a written request is correct. The underlying principle is that patient access and practice retention are not in conflict. Copies satisfy the patient's right to their diagnostic information, while the originals remain exactly where the practice's retention duty requires them to be. Question 38. Patient motion during a CBCT scan tends to. Your options are A. Sharpen the volume, B. Lower the dose, C. Ruin the whole volume, D. Shrink the field of view. Which would you go with? Lock it in before the reveal. The correct answer is C. Ruin the whole volume. Sir is correct because the reconstruction depends on many basis images taken during rotation. Movement blurs the data across the entire data set, so motion can degrade or ruin the whole volume, not just one slice. A is wrong because motion never sharpens an image. It smears the captured projections, so the reconstructed volume loses definition rather than gaining the crispness this option claims. B is wrong because the dose is set by the exposure parameters of the scan, not by whether the patient moves, so movement does not lower the radiation the patient receives. D is wrong because the field of view is chosen before the scan and fixed by the equipment settings. Patient movement degrades the image quality but does not shrink that selected field. Cone beam CT builds a 3D volume by combining hundreds of projection images taken from different angles as the machine rotates. That reconstruction math assumes the patient never moved, and when that assumption breaks, the consequences spread everywhere. As the source and receptor rotate, every basis image captures a different angular view of the same anatomy. The reconstruction algorithm combines all of these projections simultaneously, trusting that each one recorded the exact same unmoving structures. When the patient shifts mid-rotation, later projections record the anatomy in a different position than earlier ones. The algorithm cannot reconcile these disagreeing views, so it produces blurring, doubling, and streak artifacts that spread throughout the entire reconstructed volume, not just one slice. It's equally important to know what motion does not do. It cannot sharpen an image, lower the radiation dose, or shrink the field of view. Those are all fixed by exposure parameters and equipment settings chosen before the scan begins. And unlike conventional CT, motion never stays confined to a single slice. Because CBCT reconstruction depends on every projection agreeing about where structures are, even a small shift partway through the scan can ruin the entire volume. The only fix is to rescan with the patient fully still. Question 39. A dark area on an image usually means that compared with nearby tissue, the region is. Your options are A. Less dense or demineralized, B. More mineralized, C. Thicker and harder, D. Coated in metal. Don't overthink it. Which one feels right? The correct answer is A. Less dense or demineralized. A is correct because a radiolucent dark area forms where tissue is thinner or has lost mineral, so it absorbs fewer X-rays and lets more reach the receptor. Caries, bone loss, and cysts all darken the image this way. B is wrong because greater mineral content blocks more X-rays and produces a light radiopaque area. That is the exact reverse of the dark appearance the question is asking about. C is wrong because thicker, harder tissue offers more resistance to the beam, which lightens that part of the image. Density and thickness both push toward radiopacity, not toward the darkness described. D is wrong because metal is the densest material in the mouth and stops the beam almost completely, leaving a bright white area. A metallic region could never explain a darker radiolucent zone. When you see a dark area on a radiograph, you're looking at a radiolucent region, tissue that is less dense or has lost mineral compared to the surrounding structures. Dense mineralized tissue absorbs more of the X-ray beam, so the receptor beneath stays light. Where tissue is demineralized or thinned, more photons pass through and strike the receptor, darkening that area on the image. Three classic radiolucent findings share the same underlying cause: reduced attenuation, a carious lesion, an area of bone loss, and a fluid-filled cyst, all present fewer dense atoms in the beam's path, letting more photons through and appearing dark against intact surrounding tissue. The key interpretive rule is that darkness signals reduced density or demineralization, while lightness signals the opposite. Greater mineral content, thicker tissue, and metal each block more of the beam and produce lighter radiopaque areas, the exact reverse of a dark zone. Anchoring to the single principle, dark means less attenuation, which means less dense or demineralized tissue, is the interpretive move that makes radiolucent findings like a decay and bone loss visible and meaningful on every radiograph you read. Question 40. A shorter wavelength X-ray compared with a longer one has a. Your options are A. Lower frequency, B. Slower travel speed, C. Higher frequency, D. Negative charge. Got a guess? Lock it in. The correct answer is C. Higher frequency. C is correct because velocity is fixed. A shorter wavelength is paired with a higher frequency. The waves cycle more often over the same distance, and these higher frequency X-rays carry more energy. A is wrong because a lower frequency goes with a longer wavelength, not a shorter one, so this reverses the inverse relationship that the constant speed of light requires. B is wrong because travel speed does not change with wavelength, since all electromagnetic radiation moves at the speed of light, so the shorter wave does not move more slowly. D is wrong because X-rays carry no charge regardless of wavelength, so a shorter wavelength cannot give the ray a negative charge. Charge is simply not one of their properties. For every form of electromagnetic radiation, wavelength and frequency are locked together by a single constraint. The speed of light never changes. Understanding this link explains why some X-ray beams penetrate tissue deeply while others are absorbed near the surface. Because the speed of light is fixed, the only way to shorten the distance between wave crests is for those crests to arrive more frequently. A shorter wavelength wave completes more cycles per second. That is, it has a higher frequency, and that higher frequency means more energy packed into each photon. The chain runs in one direction. Shorter wavelength forces higher frequency. Higher frequency means greater energy per photon, and greater energy means deeper penetration through dense tissue. Each step is forced by the one before it, with the fixed speed of light holding the whole relationship together. Exam writers test this by reversing the pairing or inventing false properties. A shorter wavelength does not lower frequency, does not slow the wave, and does not add a charge. X-rays carry no charge at any wavelength, and all electromagnetic radiation travels at the same fixed speed regardless of wavelength. Shorter wavelength and higher frequency are two descriptions of the same rapidly cycling wave. Keep that pairing firm, and the energy and penetrating power of an X-ray beam follow directly. Question 41. A patient's image shows a thin, unbroken white line outlining the tooth socket. This line is Your options are A. Periodontal ligament space, B. Cementum, C. Cancellous bone, D. Lamina dura. Which one is it? Pause the video if you need more time. The correct answer is D. Lamina dura. D is correct because the lamina dura is the dense cortical bone lining the socket, so it absorbs X-rays and appears as a radiopaque white line. An intact, continuous lamina dura is a sign of a healthy attachment. A is wrong because the periodontal ligament space is the thin dark line just inside the lamina dura. Being soft tissue, it reads radiolucent, the opposite of the white line described here. B is wrong because cementum is the thin mineralized layer covering the root surface itself, not a line drawn around the socket. It blends with dentin and is rarely distinct on an image. C is wrong because cancellous bone forms a spongy meshwork between the socket walls, seen as a patchy trabecular pattern. It is not the crisp continuous outline that frames the socket edge. The lamina dura is the thin layer of dense cortical bone that lines each tooth socket. Understanding what it looks like on a radiograph, and why, is the key to using it as a diagnostic landmark. The lamina dura lines the socket as compact, heavily mineralized bone. Just inside it sits the periodontal ligament space, a thin band of soft tissue. These two structures appear side by side on every periapical radiograph. Because the lamina dura is compact and heavily mineralized, it absorbs more of the X-ray beam and appears as a crisp radiopaque white line. Just inside it, the periodontal ligament space is soft tissue, so it transmits the beam and reads as a thin dark line. When both lines are continuous and well defined, the supporting structures are likely sound. Four structures are commonly confused. The lamina dura is the crisp white socket lining. The PDL space is the dark line just inside it. Cementum coats the root surface and blends into dentin. Cancellous bone shows a spongy trabecular pattern, never a sharp continuous outline, when an exam stem describes a thin, unbroken white line framing the tooth socket. It is testing the lamina dura. A break or loss of that line signals disease, making this continuous radiopag border one of the most watched signs in dental radiography. Question 40. Because the thyroid is a radiosensitive organ in the field, dental imaging protects it with. Your options are A longer PD, B, a thyroid collar, C, faster film alone, D, higher kilovoltage. Take a second. Which answer would you pick? The correct answer is B, a thyroid collar. B is correct because A, thyroid collar shields the radiosensitive thyroid gland from scatter during intraoral exposures, which is why the collar is worn with the lead apron for every such image. A is wrong because A longer PAD lowers overall dose through beam geometry, but it does not specifically cover and protect the thyroid the way a dedicated collar does. C is wrong because faster film reduces the exposure needed and helps overall. Yet it does not shield the thyroid directly. The collar is what guards that gland from scatter. D is wrong because raising kilovoltage changes beam energy and contrast and would not protect the thyroid. In fact, it does nothing to shield the gland from radiation. The thyroid gland sits low in the neck, close enough to the dental imaging field to receive scattered radiation. Because it is both radiosensitive and near the beam, it deserves its own dedicated shield. The collar drapes over the front of the neck and its lead content absorbs scattered photons before they reach the thyroid. It works locally, standing directly between the scatter source and the gland, while the lead apron covers the rest of the torso. Sensitivity alone or proximity alone might not demand a dedicated shield, but together they make the thyroid worth protecting directly. This is the Alara principle in action, reducing dose to the tissues most likely to be affected. A longer cone, a faster receptor, and higher kilovoltage each reduce overall dose or change beam geometry, but none places a physical barrier over the gland. Only the thyroid collar directly covers and shields the thyroid from scatter. When an exam stem asks how dental imaging specifically protects the thyroid, the answer is the thyroid collar, the one measure that physically covers the gland and absorbs scatter before it arrives. Question 43. The term the source uses for the congenital absence of teeth is. Your options are A, supernumerary, B, concrescence, C, anodontia, D, ankylosis. Before I reveal it, which one do you think is right? The correct answer is C, anodontia. C is correct because anodontia, partial or total, is the congenital absence of teeth. The third molars are most often missing, followed by the maxillary lateral incisors and the second premolars in that order. A is wrong because supernumerary means the opposite, teeth beyond the normal number. So it names extras such as a mesiodens rather than teeth that simply never developed. B is wrong because concrescence is the joining of two teeth at the cementum of their roots, a fusion of existing teeth, not the failure of teeth to develop in the first place. D is wrong because ankylosis is the fusion of a tooth to the surrounding bone, which fixes it in place. It concerns attachment, not whether a tooth is congenitally present or missing. Anodontia is the congenital absence of teeth, not teeth that were lost, but teeth whose buds never formed in the first place. Understanding why certain teeth go missing, and how to tell true absence from other anomalies, is the core of this concept. The pattern of absence is predictable. Third molars are missing most often, followed by the maxillary lateral incisors, and then the second premolars. These are the tooth buds most prone to developmental failure. On imaging, the side of a congenitally absent tooth shows no erupted tooth and no unerupted bud waiting in the bone. This is what separates true anodontia from an impaction, where a formed tooth exists but simply hasn't emerged. The classic exam trap is confusing anodontia with anomalies of addition and fusion. A supernumerary tooth adds an extra tooth. Concrescence joins two roots at the cementum, and ankylosis fuses a tooth to surrounding bone. Only anodontia names teeth that never developed at all. When an exam stem describes teeth that are congenitally missing with no sign of a bud in the bone, anodontia is the answer. It stands apart from every other dental anomaly because the tooth never existed to begin with. Question 44. Placing a barrier over the tube head breaks which link in the chain of infection? Your options are A. The mode of transmission, B. The susceptible host, C. The infectious agent itself, D. The portal of exit only. What's your answer? Commit to one before I continue. The correct answer is A. The mode of transmission. A is correct because a surface barrier keeps the tube head from becoming a contaminated fomite. So it breaks the mode of transmission, the indirect contact link by which microbes would otherwise travel from surface to hand to patient. B is wrong because the susceptible host link is reinforced by measures like vaccination that make a person resistant, not by a barrier that simply keeps a surface from spreading contamination. C is wrong because a barrier does not destroy the infectious agent the way sterilization does. It instead blocks the route the organism would take, leaving the agent itself untouched. D is wrong because the portal of exit is where organisms leave the reservoir. A tube head barrier acts on how they travel between surfaces, not on their initial escape from a source. The chain of infection is a model describing 6 linked conditions that must all be present for an infection to spread. The key insight is that you don't need to defeat every link. Breaking just one interrupts the entire chain. The 6 links are the infectious agent, its reservoir, a portal of exit, the mode of transmission, a portal of entry, and a susceptible host. Each link depends on the one before it, so a break anywhere stops the spread. Different infection control measures each target a specific link. Vaccination strengthens the susceptible host. Sterilization destroys the infectious agent. And a surface barrier works specifically by blocking the mode of transmission, denying microbes the indirect route from surface to hand to patient. A tube head barrier doesn't kill organisms or make patients immune. It simply keeps the surface clean so it can never become a fomite. By removing the root, the entire indirect contact pathway collapses, even though the agent itself is left untouched. When an exam stem asks which link a surface barrier interrupts, the answer is always the mode of transmission. Tie surface barriers to that link, and you're reasoning through infection control rather than memorizing it. Question 45. A large dose of radiation received over a short time describes. Your options are A. Chronic exposure, B. Background radiation, C. Scatter only, D. Acute exposure. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Acute exposure. D is correct because acute exposure is a large dose delivered in a short time. The pattern seen in events like a nuclear accident, in contrast to the small repeated doses of chronic exposure. A is wrong because chronic exposure is the opposite pattern. Small doses absorbed repeatedly over a long period. Not a single large dose delivered quickly in one event. B is wrong because background radiation is the low-level natural radiation always present in the environment, not a sudden large dose received in a brief time. C is wrong because scatter describes radiation deflected from the beam, a type of stray radiation, not a way of classifying how much dose is received over what time. When we classify radiation exposure, the most important variable isn't just how much dose a person receives, it's how fast it arrives. That rate of delivery is what separates acute from chronic exposure. Acute exposure means a heavy dose arriving rapidly, faster than the body's repair mechanisms can keep up. Because so many cells are damaged simultaneously, effects like radiation sickness can appear soon after. The biological difference comes down to repair. In acute exposure, the damage arrives faster than tissues can recover, driving immediate injury. In chronic exposure, small doses spread over time allow ongoing repair, so the concern shifts to long-term statistical risk rather than sudden illness. Exam questions often pair acute exposure with three confusable terms. Chronic exposure is its direct opposite, small and prolonged. Background radiation is the low-level dose always present in the environment. Scatter is radiation deflected from the primary beam, describing stray radiation, not a dosing pattern at all. Whenever an exam stem describes a heavy dose delivered rapidly, such as a reactor accident, that's acute exposure. Hold it against chronic exposure, small doses over a long career, and the timing distinction becomes clear. Question 46. A radiopaque base under a filling can be mistaken for decay unless the assistant recalls that recurrent caries appears. Your options are A. Equally bright, B. Radiolucent at the margins, C. Metallic and dense, D. Outside the tooth. Which would you go with? Lock it in before the reveal. The correct answer is B. Radiolucent at the margins. B is correct because recurrent caries is demineralized tissue, so it shows as a radiolucent shadow at the margins of a restoration, whereas a base is a placed radiopaque material. The dark versus light contrast tells them apart. A is wrong because if decay were equally bright, it would look like the dense base, but caries loses mineral and darkens, so the two never share the same bright appearance. C is wrong because a metallic and dense describes the base or a metal restoration, not decay. Caries is a loss of tooth substance and reads dark, never as a bright metallic spot. D is wrong because recurrent caries forms within the tooth at the restoration margins, not outside the tooth. So an external location does not describe where this decay actually develops. When decay forms at the edge of an existing filling, it's called recurrent or secondary caries. Understanding how it appears on a radiograph is essential for telling it apart from the materials placed deliberately beneath a restoration. On the radiograph, recurrent caries shows as a dark, radiolucent shadow at the restoration margins, the place where the filling edge meets the tooth. Beneath the filling you may also see a bright haliopakebas, a placed liner that is intentionally dense so it can be identified. The difference comes down to density. Decay is demineralized tissue that stops little of the X-ray beam, so it reads dark. A base is a dense placed material that stops more of the beam, so it reads bright. That dark versus light contrast at the margin is the readable signal. Recurrent caries is radiolucent and sits at the restoration margins within the tooth, never outside it. The base is radiopaque and sits beneath the filling. Knowing which is dark and which is bright lets an examiner distinguish harmless liner from active disease at a glance. Question 47. Radiation exposure in air is measured in Röntgens or in... Your options are A. Grays, B. Sieverts, C. coulombs per kilogram, D. Ram. Don't overthink it. Which one feels right? The correct answer is C. Coulombs per kilogram. C is correct because exposure, the ionization a beam produces in air, is measured in Röntgens or in the modern unit coulombs per kilogram. It is never expressed in grays or sieverts. A is wrong because grays measure absorbed dose, the energy deposited in tissue, which is a different quantity from the exposure in air that Röntgens are used to describe. B is wrong because sieverts measure dose equivalent, weighting absorbed dose for biologic effect, so they do not express the simple exposure in air being asked about. D is wrong because REM is the older unit of dose equivalent, paired with the sievert, so it measures biologic effect rather than exposure in air, which Röntgens record. Radiation involves several distinct quantities, and each one has its own dedicated units. Understanding which unit belongs to which quantity is the key skill being tested. There are 3 distinct quantities. Exposure measures ionization produced in air, expressed in Röntgens or coulombs per kilogram. Absorbed dose measures energy deposited in tissue, expressed in grays. Dose equivalent weights absorbed dose for biological effect and is expressed in sieverts. Think of a dental X-ray beam. The Röntgen describes how strongly it ionizes the air at a point. The gray describes how much energy is deposited in the patient's tissue, and the sievert describes the biological impact of that energy. These units are not interchangeable. Grays and sieverts never express exposure in air, and Röntgens never express absorbed dose or biological effect. Using the wrong unit misstates what is actually being measured. When an exam stem asks for the units of radiation exposure in air, the answer is always the Röntgen or coulombs per kilogram. Grays and sieverts belong to the other quantities and are never correct for simple exposure. Question 48. Using slob, an object that moves opposite to the tube shift is located on the... Your options are A. Buccal side, B. Lingual side, C. Occlusal plane, D. Midline only. Got a guess? Lock it in. The correct answer is A. Buccal side. A is correct because by the rule, opposite means buccal. An object that appears to move against the direction of the tube shift sits on the buccal or facial side, away from the tongue. B is wrong because the lingual side is where an object moving the same direction as the tube ends up. So a structure moving opposite the shift is the buccal one, not the lingual. C is wrong because the occlusal plane is the biting surface level, not a buccal or lingual position. So it does not answer where a shifting object lies side to side. D is wrong because midline only describes a front to back center position. Slob resolves buccal versus lingual location, so the midline is not what the rule determines here. When a dental tube is shifted and an object appears to move in the opposite direction, that object lies on the buccal side, toward the cheek and away from the tongue. This is the core of the same lingual opposite buccal rule. The rule pairs direction of apparent motion with anatomical location. If the object moves the same direction as the tube, it is lingual. If it moves opposite to the tube, it is buccal. That single contrast is the entire decision. The underlying mechanism is parallax. Because the buccal object sits farther from the receptor and closer to the tube's path, it appears to swing opposite the tube's movement. That opposite swing is the geometric fingerprint of a buccal position. Exam writers exploit 3 confusable answers. The lingual side is for same direction movement. The occlusal plane describes a biting level, and the midline describes a front to back center. Neither has anything to do with the cheek or tongue axis, the rule resolves. Whenever a stem describes an object moving opposite to the tube shift, the answer is buccal. Tying that opposite swing specifically to the cheek side is what completes the localization decision. Question 49. In a steam autoclave, the agent that actually kills microorganisms is... Your options are A. The pressure, B. The water by itself, C. The metal packaging, D. The heat. Which one is it? Pause the video if you need more time. The correct answer is D, the heat. D is correct because in a steam autoclave, it is the heat that destroys microorganisms. The pressure exists only to raise the steam to the high temperature needed, so the lethal factor is the heat itself. A is wrong because pressure alone does not kill microbes. Its role is to allow the steam to reach a high enough temperature, and that temperature is what does the actual killing. B is wrong because water by itself, without reaching sterilizing heat, will not kill resistant organisms, so the unheated liquid is not the lethal agent in the process. C is wrong because the packaging protects and maintains sterility after the cycle, but it plays no part in killing microorganisms, which is accomplished by the heat. In a steam autoclave, it is the heat, not the pressure, that actually destroys microorganisms. Understanding why requires looking at what each component of the process actually does. The autoclave works through three linked factors. Heat is the lethal agent that denatures proteins and destroys spores. Pressure raises the boiling point of water so steam can climb above normal boiling temperature. And steam is simply the medium that carries that heat efficiently into instruments and packs. Inside the sealed chamber, elevated pressure lifts the boiling point of water, allowing steam to reach temperatures well above what an open vessel could achieve. That superheated moist steam transfers energy directly into the load, and the sustained high temperature destroys even resistant bacterial spores. The exam trap is crediting the wrong feature. Pressure alone does not sterilize, it only lets heat reach a lethal level. Water without sterilizing heat cannot kill resistant organisms. And packaging maintains sterility after the cycle but plays no role in the killing during it. Whenever an exam asks what destroys microorganisms in a steam autoclave, the answer is the high temperature. Pressure is the enabler, but heat is always the lethal agent. Question 50. In radiography, most cross-contamination occurs through. Your options are A. Direct mouth contact, B. Indirect contact with touch surfaces, C. Sterile instruments, D. The primary X-ray beam. Take a second. Which answer would you pick? The correct answer is B. Indirect contact with touch surfaces. B is correct because cross-contamination in radiography is mostly indirect, traveling by way of surfaces and objects a contaminated glove touches, which is why barriers, aseptic technique, and hand hygiene are emphasized. A is wrong because direct mouth contact does transfer organisms, but the dominant route in imaging is indirect. Through the many surfaces, a contaminated glove touches between steps. C is wrong because sterile instruments are free of organisms by definition, so they are not the root of contamination. The risk lies in contaminated surfaces touched indirectly. D is wrong because the primary beam is radiation, not a vehicle for microorganisms, so it cannot spread infection. Contamination instead travels by physical contact with touch surfaces. In dental radiography, most cross-contamination doesn't happen through dramatic direct contact. It travels quietly through the many surfaces a contaminated glove touches between steps. A glove that contacts the patient's mouth then grips the tube head, presses the exposure switch, and handles the receptor, depositing organisms on every surface it touches. Each surface becomes a temporary reservoir, called a fometer, passing contamination along to the next person who touches it. Three factors make indirect transfer the dominant route: the sheer number of surfaces touched, the ability of those surfaces to hold organisms, and the chain-like relay that moves contamination across the room to the next patient or operator. Direct mouth contact is a minor route compared to surfaces. Sterile instruments carry no organisms by definition. The primary beam is radiation, not a vehicle for microbes. Only the indirect surface-to-hand route drives the bulk of spread. This is why infection control and imaging lean so heavily on surface barriers and hand hygiene. Both directly interrupt the indirect relay before contamination can reach the next patient.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.